Breast cancer strikes 1 in 8 women in the United States. Learn about the risks, screening, and preventive steps that you can take in this edition of Physician Focus with the Massachusetts Medical Society. Welcome to Physician Focus. I'm Dr. Dale McGee. Breast cancer is one of the most common cancers in women, second only to skin cancer, and about 1 in 8 women will develop invasive breast cancer during their lifetime. The good news is that the death rates from this disease have been declining for some 25 years, largely due to better treatment. The standard for preventive care has been the mammogram, yet differing opinions from health professionals about this screening have raised concern and confusion. Some research has indicated that mammograms have led to the overdiagnosis of some breast cancers that would not have otherwise been a risk to the patient's health. The advent of genetic testing and the growing acceptance of preventive mastectomies have added to the concerns. This edition of Physician Focus will discuss several important aspects of breast cancer. We'll look at the risk factors for the disease, strategies to reduce those risks, the effectiveness of current thinking on screening techniques, and concerns about genetic testing and preventive surgeries. With me for this discussion are Drs. Nadine Tung and Gerberg Wolf, two board-certified medical oncologists from the Cancer Center at Beth Israel Deaconess Medical Center in Boston. Both are also associate professors of medicine at Harvard Medical School. Welcome, doctors.
Hello, thank you.
So, Dr. Tung, how common is breast cancer? We say 1 in 8 women. What does that really mean? Does 1 in 8 women actually get breast cancer during their lifetime?
Well, 1 in 8 women, 12% of women would get breast cancer if they lived until age 90 and they didn't die of some other medical condition. So yes, it depends on what age a woman lives to, but I think 1 in 8, because women are living longer, is what we tend to say.
So it's a pretty common disease.
It is a common disease.
Are all cancers the same? Is every cancer equally bad?
No, there are different types of breast cancer. We're used to saying now that breast cancer is not one disease. Some of them are more aggressive, some less. And we tend to think about breast cancer in different subtypes or different groups that really have directed better treatment, leading to better cure rates.
Mm-hmm. And do we know when we do a biopsy whether this is a breast cancer that is aggressive or not aggressive? Have we been able to tell that?
So I think the important thing is that our tools have become much more precise. So when we're now assessing how much of a risk does this particular breast cancer really constitute to you, the patient, we have many more tools available to understand that. And that ranges from the risk factors such as your age, your the risk factors, for the clinical risk factors as a person, but also, in your biopsy, is this a high grade, is this a low grade tumor? And then we can send out this tumor and understand much better what particular risk factors assign a score. How risky is this breast cancer really for you? And what steps do we need to plan to make sure that this does not come back to haunt you?
So we know more than we once did. There was a time where it was cancer or no cancer. Now it's cancer, and they look at the cells. Are these cells very aggressive? They look at the various molecules within the cells and try to put it in a category where we'd worry about it more, worry about it not as much. Right. Although it's never good news.
We used to rely just on how it looked under the microscope. And now what Dr. Wolf was referring to is that we're able to take a piece of that tumor and really analyze what genes, just a fancy word for instructions, what instructions in that tumor are on or off. And that really predicts the behavior of that tumor and really directs how we treat specifically personalized medicine a little bit more.
So this kind of leads to treatment. And one of the things we said in the introduction was that there's been a substantial improvement in the survival. 1 in 8 women may get breast cancer, but 1 in 8 women don't die of breast cancer. It's a much lower number, I imagine. And that has to do with the treatment. Can you tell us a little bit about the thinking regarding treatment?
So treatment for breast cancer, most women have their breast cancer diagnosed via a mammogram. So the treatment really starts right then and there. For most women, the treatment is surgery, having this cancer removed. And then the question really is, what, after the surgery, we know what kind of tumor it was, how large was it, had it spread to the lymph nodes, did it not spread to the lymph nodes? And that information will then help us to make decisions. Do you need radiation to make sure it doesn't come back locally? Do you need medical treatment? And if so, what kind of medical treatments are warranted to minimize the risks that this might come back?
So there was a time when mastectomy was the treatment of choice, but now it's moved to a more local excision. What is more common right now? Are more women opting for a mastectomy or for just a local excision?
I think, as we call it, breast conserving therapy, allowing a woman to keep her breast is really the goal. It should be the exception that a woman has a mastectomy, because studies involving thousands of women who've participated in research have demonstrated that the survival is the same. If the surgeon can remove the tumor with a good healthy rim of normal tissue around it to show that it's all been taken out, there's really no improvement in survival from doing a mastectomy. There are some exceptions about who should have a mastectomy, but the goal, and the vast majority of women should be able to keep their breast.
And the radiation therapy, has that changed over the years?
It certainly has. I mean, now there are certainly women who, even after the tumor is removed, do not need radiation, and that's being explored. Older women that have smaller tumors, that tend to be slower growing tumors, they may not need radiation. And others who get radiation, it used to be 5 or 6.5 weeks of radiation. Now we have studies to show that doing it for 3 weeks is equally as effective for the majority of women. So I think one of the great things about the result of all the studies has shown that even if treatment is needed, it can be shortened, it can be less toxic, and indeed sometimes it's not even needed.
And chemotherapy, how has that changed over the years?
Well, I think we are much more precise now in knowing who would benefit from chemotherapy and who does not. So when a woman comes with stage 1 or stage 2 breast cancer, a cancer that's just in the breast or maybe has affected a few lymph nodes, we now have, in addition to clinical parameters, and that's just the grading of the tumors, additional genetic information available to us. It will allow us to understand the biology of this cancer much better, and will allow us to make more precise recommendations as to who should be having chemotherapy to prevent this from recurring. And certainly a lot of women with estrogen receptor positive breast cancer will benefit much more from estrogen receptor blockade than from chemotherapy.
And I think that this just leads to the fact that the cure rates are much higher, and that when a lot of women hear this 1 in 8 number, they think 1 in 8 are going to die. A diagnosis of cancer means a death sentence. And you're basically painting a picture that treatments have improved a great deal here. And therefore the cure rates are much higher. Can you give us a sense as to what those numbers are?
Well, I think to put it in perspective, an early stage breast cancer is frequently a much more curable situation than hypertension or diabetes. It's really a condition that's diagnosed, can be dealt with, and the woman can then move on and live a healthy life. In the majority of cases, that's really the case. So this is an obstacle that can be overcome, and the prognosis is overwhelmingly good for the vast majority of women who are getting diagnosed with early stage breast cancer.
I would echo that completely. I think breast cancer is one of those cancers that our expectation in the vast majority is cure. So 1 in 8 does not mean death from breast cancer. 1 in 8 means that it's diagnosed, but the vast majority will be cured. There have been developments in the last decade that have taken some forms of breast cancer that were the most aggressive, a particular type that's fed by something called HER2, and there have been new developments, new treatments that now make that perhaps the most curable type of breast cancer. So really specific treatments, personalized medicine, have just improved the treatment and the cure rate for breast cancer.
Very encouraging. So I guess the next thing we'd want to think about here is, are all women of equal risk, or are there factors in one woman or another that would raise their risk for getting breast cancer?
Right. Well, there are different risks, and I think they fall into different categories, but for example, one of the risk factors is a family history. And I think a family history, particularly if there are relatives with young breast cancer in the family, because developing cancer at a younger age often implies there may be an inherited risk rather than a woman who has two aunts who are in their 70s with breast cancer. So I think family history of breast cancer is a risk factor. I think sometimes when a woman has a breast biopsy and it's completely benign, it's not cancer, we do see changes, some abnormal or atypical cells that indicate a woman's at increased risk. So I'd say certain types of biopsies, certain family history, and there are some other risk factors, but yes, different risk factors can predict.
So you mentioned young relatives. So how would you define young for having a breast cancer?
So typically for adults, young is when breast cancer is diagnosed before the age of 50.
Okay.
So I think that's the age that we tend to think about. So if somebody does have relatives with young breast cancer, or has relatives with ovarian cancer, because those two cancers sometimes run together, they cluster together in some inherited risk syndromes. Okay. So that tends to get our attention.
And what about taking the birth control pill? Does that raise the risks?
So birth control pills, that's a great question. I would say that there's not convincing evidence that modern day birth control pills increase the risk of breast cancer, but I think the data is inconsistent. I think birth control pills before 1976 had very high estrogen levels, and there was no doubt they raised the risk. I think modern day ones have much lower levels, and so I think some studies have shown that if they're taken for a long time or started very young in life, perhaps there's a modest small increase, but I don't think those findings are consistent. So my feeling is that since it's not conclusive, and effective birth control is such an important goal for women, that we don't have data to say that a woman should not be able to use oral contraceptives because of the risk of breast cancer.
And what about hormone replacement therapy? A woman goes through the menopause and may go on hormone replacement therapy. Would you advise them that they're at increased risk? Do they have to be screened differently?
I think that has been unequivocally shown that some forms of hormone replacement therapy can increase the risk of breast cancer, and particularly the risk of breast cancer, of estrogen receptor positive breast cancer. So I think that the practice of prescribing hormone replacement has shifted towards thinking about addressing the problems that hormone replacement trying to address in different ways, and then thinking more about lifestyle and other factors rather than using hormone replacement. I think it is so important to consider risk factors for breast cancer when considering hormone replacement. So do I have a family history of breast cancer? Do I have a long-term history of smoking? Am I overweight? Those kinds of personal factors may influence, whether I can take hormone replacement or not. Am I at a high risk of osteoporosis? Is it important for me because the prevention of bone loss is frequently a reason why women choose to go on hormone replacement? I mean, I think these are very individual decisions that should be discussed with a physician, but these are the factors to consider.
So I've commonly heard from patients, I don't think I need to be screened because no one in my family's had breast cancer. And I guess the converse of what I'm asking you about risk factors is, if we look at all these risk factors, how many people who get breast cancer don't have a family history of breast cancer?
The majority.
Yeah.
And so I think the unfortunate part is that even though we can identify these risk factors, if you have them, you're at increased risk. The majority of women who develop breast cancer don't necessarily have risk factors or strong risk factors, and we have to remember that age is the #1 risk factor. that 3 out of 4 women who develop breast cancer will develop it after the age of 50. They may not have a strong family history, and it's just simply aging. So unfortunately, while we know of some risk factors, we're really not that perfect in an individual woman at being able to predict her risk of getting breast cancer or not.
So I think we're still learning a lot. We don't know everything. The models we have are the best we can do right now. And you know,
they're imperfect.
That I think sort of filters through things. Well, that brings us to screening and mammograms. What do you think? There were recommendations that mammograms start in the average risk woman at age 40 and go every year indefinitely. Over the past several years, there have been a lot of discussions as to whether that is really a good idea. Talk to me about that a little bit.
All right, let me frame this a little bit and then tackle it a little bit. I think one of the issues is that when we do look at other countries who do less mammography, they do it every other year rather than every year. They don't start at 40, they start at 50. It's hard to show that survival rates from breast cancer are better in our country by doing more mammography. So what's the issue? I would frame it in 2 ways. It's how good are mammograms in general, and how good are they in young women is a specific question which has received a lot of attention. So let's talk about how good are they in general. I think it's still important to say that mammograms are really the only screening study that have been proven to decrease mortality or death from breast cancer. So I think we really have to say that it does decrease mortality. I think the problem or the controversy that you alluded to in the introduction is that they tend to pick up cancers that are slower growing or perhaps less dangerous to a woman. They're not as good necessarily at picking up a fast growing or aggressive cancer. So one of the issues is, are we just simply picking up more cancers that if we had waited until we felt a lump, the doctor felt a lump, the patient felt a lump, it would really be the same. That's one of the issues. And specifically, one of the emotional and controversial issues is women age 40 to 50. And that's because mammograms are just not as good in younger women in general as they are in older women. And that's because when women are younger, when they're menstruating and they have very high estrogen levels, their breast tends to be what we call dense. Now that's not something you can feel on exam. That's not firmer breasts. That means on the mammogram, the breast tissue is white. And unfortunately, cancer is white. And so it masks the detection of cancer when a woman is young and she has these dense breasts on mammogram. And so mammograms are less good in younger women, and they may not be as good as we wish they were in general for all women. And the question is really, how many lives do they save? I would point out that the radiologists would argue that a lot of these studies have been done with older mammography techniques. And mammograms have gotten better, just like a camera. They're now digital, they're not film, they're 3D, not 2D. And I think that is part of the discussion, that perhaps the technology has gotten better. So it is controversial. I still maintain that I think women age 40 should start annual mammograms. And I would say especially or particularly if they have a family history or they have a biopsy suggesting any atypical cells, something that does give them a risk factor. That's how I would summarize it.
So another issue that comes up, though, that you briefly alluded to in talking about the different kinds of cancer, some grow very rapidly and spread very early, others may not. And it seems that one other thing we're finding is with these very sensitive tests, we may be finding some cancers that the body left to its own defenses would have kept in check for the rest of the woman's life. And she may not have required treatment. Is that something that is a concern? Is that common?
That is certainly a possibility. We find more of what we now call stage 0 breast cancer, the ductal carcinoma in situ, the cancer that has not yet become invasive. We also find more irregularities on a mammogram that may even be something called atypia, so not even a precancerous lesion. So clearly we have a higher sensitivity for changes that might put a woman at risk for breast cancer. It might constitute a risk factor for later breast cancer, but are not cancer in itself. And so is it a bad thing to find that? I think that if we're picking up on this risk factor, and if a woman gets diagnosed with that and has a candid discussion with her physician about that, what does it mean? What does it mean for my screening schedule? Is there a preventative medication that I should take, or maybe not? Or is there a lifestyle change that I could institute to decrease my risk of breast cancer? Then I think even those findings may actually be a good thing.
So you bring up an important point, and that is that some people are of such risk that certain preventive steps beyond just getting mammograms are recommended. And you'd mentioned medications. Could you paint a picture for who might qualify for that kind of treatment?
So, for example, a woman that's diagnosed with stage 0 breast cancer, non-invasive breast cancer, she might have a discussion depending on how extensive this was. Her risk of breast cancer may be 2 or 3 times higher than it would have been without that diagnosis. And she might decide on a course of a medication called tamoxifen to reduce her later risk of invasive breast cancer. That would be a situation.
Do those treatments have any risks? Does the tamoxifen have risk?
Certainly, any medication that a physician prescribes has potential risks, and specifically tamoxifen comes with risk factors. These risks are an increased risk for strokes and heart attacks if used in older women, particularly. They come with an increased risk of uterine cancer, while they're also decreasing the risk of breast cancer. So it has to be a risk-benefit assessment and a thorough discussion about that.
Right, it's not for everybody.
Yes,
And
absolutely
so we've also heard about preventive mastectomies. Can you let us know a little bit about that?
So I think preventive mastectomies is really the most extreme form of prevention. And so I think it's really reserved in general for women who have the highest risk of breast cancer. And that's generally women who've really inherited these faulty genes from either their mother or their father. They're known, for example, as BRCA1, standing for breast cancer 1, or BRCA2, these genes. We heard a lot about them with the Angelina Jolie and all of that media attention. So I think for women who inherit those kind of faulty genes, we're talking about a lifetime risk of breast cancer, not of 12%, 1 in 8, but we're talking 80 or 90%. And I think for women with that risk, it's appropriate to talk about preventative or prophylactic mastectomies. And even having said that, it's a choice. I think for women who are at risk for breast cancer from those genes, there's also an association and an increased risk of ovarian cancer. And just to contrast ovarian cancer and breast cancer in those women who've inherited these genes, ovarian cancer, there is no good screening. It's a very hard cancer to cure. And so to prevent that cancer, it's always preventative surgery. It's always removing the ovaries when a woman is done with childbearing. But for breast cancer, we have good screening. I'm sure we're going to even talk about MRIs and other screening. We have good screening. We are very much better at curing breast cancer. So it's really a choice about whether to do something as extreme as preventive surgery or not.
So you brought up MRIs. And the good news is they don't have any radiation associated with them, so that relieves some people's concerns. Give me a brief look at the upside and the downside on that.
Okay, well, for MRIs, they are what we tend to say more sensitive, which simply means they're better at picking up breast cancer than mammograms, no question about it. But because they see so much, they see a lot of things that are not cancer, and it's not clear what they are. And so the bottom line is that there are more false positives. When a woman has a breast MRI, there's a higher chance than when she gets a mammogram that they're going to see something and say, you have to come back in 6 months, or we think you need a biopsy. And that can create a lot of anxiety, a lot of stress. So I think that the MRI, while it's better at picking up breast cancer, it really should be reserved for women who have a higher risk of developing breast cancer. The American Cancer Society says that risk should really be about 20 to 25% at
Lifetime
least.
risk. Okay. So that's basically a discussion with their doctor and to go over their risk factors. Who should be screened for the genetics, for the BRCA1 and BRCA2 gene? This is also something which should be used selectively. It's not for everybody.
Definitely not. I think this is we cast an ever wider net. And again, this is something that a woman should be free to discuss with her healthcare provider. That this is, in our times, this is an appropriate question. Is there genetic testing that I should take to understand my breast cancer risk? And women who should ask that question are women who developed the first breast cancer at the age of 50 or younger, women who had breast cancer twice, certainly there's a concern. Women with a family history of breast cancer in their first degree relatives, or women who had a man in their family who had breast cancer. That's a consideration. There's also, as Dr. Tong was pointing out, a connection between ovarian cancer and sometimes pancreatic cancer and breast cancer. So if there's a cluster of cancer in your family, this is an important question to consider. So it's not only an age question, it's not only a direct family history question, but there are a number of constellations that could lead to genetics testing, and so I think it's a good thing to think about.
Okay, so we've covered quite a bit. What can we leave our viewers with regarding what they can do to lower their risk?
I think there are three major things we've learned that women can do to lower their risk of breast cancer. The first is to keep their weight down. Weight loss at any age, even teenage years, decreases the risk of subsequent breast cancer. Limit alcohol. We say it doesn't have to be 0, but try to minimize to 3 to 4 a week or less if you're trying to do everything you can to lower the risk of breast cancer. And exercise, even 3 to 4 times a week. Get your heart rate up 20 to 30 minutes, and that'll decrease the risk.
Wonderful. Well, thank you for leaving us with that. Dr. Wolf, Dr. Tong, it's been great. Thank you for being with us today.
Our pleasure.
Thank
For
you.
more information on breast cancer, visit our website at physicianfocus.org. I'm Dr. Dale McGee. Thank you for watching.
I'm Dr. Gerber Wolf.
And I'm Dr. Nadine Tung.
About 1 in 8 women will develop breast cancer in their lifetime. The good news is that death rates have been declining because of increased awareness and earlier detection.
Early detection is critically important, as it improves the chances that the cancer can be treated successfully with more treatment options that can result in better outcomes.
Current recommendations are that women in the 20s and 30s without symptoms should have a clinical breast exam every 3 years.
The risk of breast cancer increases with age, however, and women should consider screening tests beginning at age 40.
Women can also reduce the risk of breast cancer by eating a healthy diet, getting regular exercise, and drinking fewer alcoholic beverages.
For more information on preventive measures and screening, visit the American Cancer Society at cancer.org.
I'm Dr. Rob Friedman. Cancer is the second leading cause of death in the United States, surpassed only by heart disease, and claims nearly 600,000 lives each year. This year alone, nearly 2 million new cases of cancer are projected to be diagnosed, nearly 38,000 in Massachusetts alone. Yet many of these could have been prevented. Healthy lifestyle choices, a good diet, physical activity, protection from the sun, and a tobacco-free life can dramatically reduce your risks for cancer. Vaccines are available to prevent cervical and liver cancers caused by infections from hepatitis and human papillomavirus. And screening can prevent breast, colorectal, and cervical cancers and detect many other types of cancers early when treatments are most effective. Talk with your doctor about the steps you can take to prevent and reduce your risks for cancer. To learn more, visit cancer.org.